thankful to Dr. Hunavar for giving me the opportunity to see his patients all through these years and for the talk that I'm giving on his behalf. So I'll be talking on the role of plaque brachytherapy in retinoblastoma. And when we talk about plaque brachytherapy, we have the major radionuclides that are iodine, palladium, and cesium, which are photon emitters, and we have ruthenium and strontium, which are beta emitters. So these are the radionuclides that we deal with. More often, we deal with iodine and ruthenium out of these for treating ocular tumors. And everything depends on the half-life and the energy, so good detailing and information about half-life and energy is important so that we can land up planning the treatment going forward. So when we talk about the indications of plaque brachytherapy, could be surface neoplasms and intraocular tumors as well, but I'll be specifically talking on retinoblastoma. So when we talk about the history of how plaque brachytherapy evolved, so focal radiotherapy was used for ocular tumors in late 1929 in England by Moore and Associates. They used the radon seeds, and eventually Szilard took up, and Szilard was the one who introduced plaque brachytherapy to retinoblastoma. And then came the episcleral plaques, cobalt plaques, and eventually revisions have been made in the radioisotopes, implant design, the placement technique. And when we look at the current times, iodine is technically preferred in US and other countries, and ruthenium is more preferred in European and Asian countries, and I'm sure that there are still centers which prefer iodine in India as well, but majority of the centers would use ruthenium, and I think the panel would also agree. So when we talk about the old papers that all the way in 1993, that is when when everything was evolving, and even plaque brachytherapy was used as primary and secondary treatment. So as you can see over here, even 30% of the cases were treated as primary treatment to retinoblastoma. The times have evolved now, because nowadays I think everybody would prefer to reserve plaque brachytherapy as a secondary treatment, and even though the studies were performed, the rate of tumor control and patient survival were pretty much similar, whether as primary treatment or secondary treatment. So when we talk about primary brachytherapy, it is less common. I guess if the panel would agree that plaque brachytherapy as primary would be in cases where you have a very stenosed ostium for IAC, and maybe IVC is contraindicated. So in those cases, we can still think about primary brachytherapy, but I guess primary brachytherapy has its own complications, so we land up keeping it for the reserve, and of course we have to treat the patient systemically as well. And secondary brachytherapy that is more preferred would be after previous treatment failure in terms of IVC, IAC, cryotherapy, laser, intravitreal topotecan, periocular topotecan, or even a combination of all, which is basically tailored management. So the process of brachytherapy is not that easy. It involves an entire planning, and it involves a lot of people. It's a multidisciplinary approach. You need to have your radiation team as well. So it's from the clinical assessment all the way to regular follow-ups. Single thing is important in brachytherapy. So let me walk you through those. So when you do brachytherapy, as we prefer it as secondary brachytherapy, it's given in residual tumors. So the patients have been saturated, the lesion is still left aside, not responding to things, then we go for refractory tumors. Tumors which are found over calcified mound but not very high on the calcified mound can also be treated with radiation. If we have tumors overlying a calcified mound like way above 5 mm maybe, then the radiotherapy cannot reach that, so we avoid those cases. We give it within 5 mm of height, and poor vasculature. So these are the lesions where the chemotherapy drugs cannot reach, and what do you do? So the only resort that would be left would be to proceed with radiation. And macular tumors, of course, because you're not looking at a visual prognosis there, and you want a good response. And even the cases with overlying vitreous seeds, that means just adjacent to the tumor, they respond very well to brachytherapy. So this is the part where the clinical assessment comes in. Then we move on to the part where we have to assess while doing the examination under anesthesia. We must do clear measurements of the tumors. And it's important to know that, because as you are planning with iodine, you can still go to the extent of 8 mm, But with ruthenium, we don't go beyond 5 mm. So it has been proven earlier that the primary treatment tumors in the previous papers, this is paper in 2001 published in Ophthalmology, where the primary treatment tumors were slightly thicker and closer to foveola and optic disc. However, I know that the current trends have changed because we're looking at the secondary treatment only, and we must always do a B scan intraoperative for the pre-planning to make sure that we have the height in our hands to proceed with the dosimetry planning. So documentation is always very important. So when we talk about ruthenium, ruthenium is basically, it's electroplated over a silver foil, and then there is a 0.7 mm of backing and a 0.1 mm of a window, and this entire thing makes a 1 mm plate, which is basically placed over the globe, over the area of interest, and therefore tumor regression occurs. So this is how the ruthenium planning is done, and we must always remember that we prefer a dose range of 40 to 45 gray, and I think we have kind of gone a little comfortable with using 45 gray in our patients, and we always make sure that the foveola is safe still, and we give approximately 11 gray is okay. But of course, as when we are talking about the cases where visual prognosis is not our priority, there we can go ahead with 40 gray to the macula as well. This is not the representation for RB, but this is just to show that there's a lot of planning that goes in. Our radiotherapy team actually has multiple softwares in which the tumor is embedded, and after that a whole planning is done, the calculations are performed, and after which the dose duration is decided. So after the entire dosimetry planning, technically the radiologist tells us that, okay, so now you're going to place the plaque for XX number of hours, and that's how we plan our insertion and removal. So when we talk about iodine, it's slightly different. In the iodine plaques, technically you can decide the exact placement of the seeds, but in radionuclide, you can in ruthenium, you don't decide the number of seeds per se because it's an entire plate. So you have to decide according to the duration there. And we perform the surgical insertion. This is a little video where the peritomy is performed in the region, which is the targeted region. And this is a case where there's a temporal tumor, and you go around the muscles, you hook the muscles for the traction, and you do a careful dissection. You look out to the vortex veins, and from the limbus you calculate the distance, you pass the sutures with the ethylon, and you make sure that there are thin sutures that you're passing. You place the plaque over the eye, you tie the sutures on both the eyelids, and you keep it intact for the desired duration and take the plaque out. Ultrasonographic plaque placement can also be performed to make sure that you are on the right plane. And in Caucasian eyes, we can even do transillumination. So transillumination helps us identify the site of tumor. However, in Caucasian and Indian eyes or Asian eyes, it's not possible to do so. And you must keep in mind that the radiation duration is variable in ruthenium, but in iodine it's quite fixated. So it's calculated by the radiologist, as I said. Sorry, radiation therapist. And regular follow-ups are also mandatory, and we must look out for the complications that can occur. Comfortably, radiation does cause retinopathy, maculopathy, papillopathy, cataract, glaucoma, and even scleral necrosis. You must look out for those, even though the tumor control is very high. In this study, the tumor control was 83% in 1 year and 5% at 79 years. And recurrence should also be looked out for, so you must have regular follow-ups. You must call these patients at 4-monthly interval is what we follow. Initially, we start with 1 month, and then we get comfortable and we go for 4-monthly follow-ups. And we are also giving anti-VEGF injections these days, and which helps us out in preventing the radiation retinopathy. And when we talk about the follow-ups, documentation is extremely important. This is a case where over the calcified mount, the tumor has completely regressed. This is a picture of one for of 13 months. Life salvage is 100% in our study, with 85% eye salvage and even 65% vision salvage, which is pretty interesting. And we must know that plaque brachytherapy causes sustained regression of tumors, which is what we are looking for. So keeping all of this in mind, it's an entire planning which is required and must be done meticulously. So poor response is also seen in our cases. So this is a case which was stable, regressed earlier. Pre-plaque, there is, like you can see, activity right there. The tumor is completely fulminant, and there were seeds all around, and it did not work. So post-plaque 2 months, the tumor was still refractory. We had to enucleate. So the studies that have been done earlier from 1989 onwards, multiple combinations have been tried. We are now in the year of 2025, and we have symmetrically given ruthenium for our cases with an apex dose of 45 gray, and as I said, we titrated between 40 to 45 depending on the location, and we were able to achieve an eye salvage of 85%, which is a very promising number, and we kind of feel very comfortable using plaque brachytherapy as secondary brachytherapy. Secondary treatment, and of course complications of radiation retinopathy and cataract do occur. So to conclude, brachytherapy is universally acceptable treatment modality given as primary or secondary, but we prefer as secondary, and various radioisotopes, iodine and ruthenium primarily have been used at a radiation dose of 40 to 45, and profile active anti-VEGF have shown protective effect, and excellent life, eye and vision salvage rates can be seen. And I thank you all for listening to my mentors, our patients and their parents, and the entire team for their positive mindset, because everything is all about one day at a time. Thank you so much.
Thank you, Rolika. That was an excellent talk, and beautifully you covered the important topic of plaque